Chronic pain is pain that persists or recurs for more than 3 months, associated with actual or potential tissue damage, is multifactorial, biological, psychological, and social factors contribute to the pain syndrome. Chronic primary pain is pain in one or more anatomical regions that is characterized by significant emotional distress, anxiety, anger, frustration, or depressed mood, or functional disability, interference in daily life activities, and reduced participation in social roles. The diagnosis is appropriate independently of identified biological or psychological contributors, unless another diagnosis would better account for the presenting symptoms. Chronic pain tends to be very difficult to manage because of its complex natural history, mixed etiology, and poor response to therapy. Chronic primary pain can coexist with chronic secondary pain. Chronic pain is not simply a physical problem. It is often associated with severe and extensive psychological, social, and economic factors. Apart from poor general physical health and disability, there may also be depression, unemployment, and family stress. Many of these factors interact, and the whole picture needs to be considered when managing individual patients. The impact of chronic pain on patients' lives varies from minor restrictions to complete loss of independence. Moreover, National Institute for Health and Care Excellence and ICE guidelines remind us that whilst analgesics can be effective for pain relief, we must expect them to fail in the majority of patients. The focus should be on improving quality of life, and non-pharmacological options as well as analgesia must be explored. Excessive prescribing of analgesics, particularly opioid analgesics, has the potential to do more harm than good. The International Classification of Diseases, ICD-11, definition of chronic pain includes chronic primary pain, chronic cancer-related pain, chronic post-surgical or post-traumatic pain, chronic secondary musculoskeletal pain due to inflammation associated with structural changes or due to nervous system disease, chronic secondary visceral pain from mechanical factors, vascular mechanisms, or inflammation, chronic neuropathic pain, central neuropathic pain or peripheral neuropathic pain, chronic secondary headache or orofacial pain due to oral facial disorders, dental pain, neuropathic orofacial pain, or secondary temporomandibular disorder. The ICD-11 definition of chronic primary pain includes chronic widespread pain, CWP, diffuse pain in at least 4 or 5 body regions, complex regional pain syndrome. CRPS is preceded by a noxious event and is characterized by spontaneous pain or hyperalgesia, hyperesthesia, not limited to a single nerve territory and disproportionate to the inciting event. There is accompanying edema, skin blood flow, temperature, or pseudomotor abnormalities, motor symptoms, or trophic changes. Chronic primary headache or orofacial pain. Headache or orofacial pain that occurs on at least 50% of the days during at least 3 months. Chronic primary visceral pain, pain localized in the thoracic, abdominal, or pelvic region. Chronic primary musculoskeletal pain, pain in the muscles, bones, joints, or tendons. There are many possible causes of chronic pain. It may be caused by an acute injury, an ongoing degenerative illness, a primary condition, surgery, or medical interventions. Chronic pain may be due to musculoskeletal causes, including ankylosing spondylitis chronic or repetitive overuse, connective tissue disorders, for example, Ehlers-Danlos syndrome, systemic lupus erythematosus, faulty posture, fractures, mechanical low back pain, muscular strains, myofascial diseases, for example, a temporomandibular disorder, osteoarthritis, osteomyelitis, polymyalgia rheumatica, polymyositis, rheumatoid arthritis, neurological causes, including brachial plexus traction injury, complex regional pain syndrome, pernicious anemia, polyneuropathies, polyradiculopathies, postherpetic neuralgia, thoracic outlet syndrome, thyroid disease, trigeminal neuralgia, headache. Causes, including medication overuse, giant cell, temporal arteritis, glaucoma, migraine, temporomandibular joint dysfunction, trigeminal neuralgia. Psychological causes, including anxiety, depression, personality disorders, Sleep disturbances. Localized or regional pain may involve specific sites or regions. Cardiovascular, angina, dermatological, gastrointestinal, pulmonary, for example, chronic obstructive pulmonary disease. Urological, for example, chronic cystitis. Widespread pain may occur with systemic conditions such as cancer, for example, multiple myeloma. Endocrinological disease, for example, diabetes mellitus. Hematological disease, for example, non-Hodgkin's lymphoma, including Waldenström's macroglobulinemia, lymphoplasmacytic lymphoma. Infectious disease, for example, HIV. Rheumatological disease, for example, ankylosing spondylitis. Risk factors. Demographic risk factors for chronic pain include female gender. Men are less likely to report or experience chronic pain. Age over 45 years. Socioeconomic status. People who are socioeconomically deprived are more likely to experience chronic pain, and it is more likely to be severe and result in a greater level of pain-related disability. Employment status and occupational factors. Chronic pain is more common in people who are unemployed and manual workers. Lifestyle risk factors include cigarette smoking, drinking alcohol, inactive lifestyle. Exercise and physical activity have positive effects on chronic pain with improved quality of life and physical function, reducing pain severity and few adverse effects. Clinical risk factors include acute back pain with neurological signs, multimorbidity, comorbid personality disorder, psychological distress, pain-related disability, history of trauma or chronic pain, sleep disorders. Poor sleep increases the intensity and duration of chronic pain. Surgical and medical interventions, obesity. Two other risk factors include family history of chronic pain syndromes, for example, migraine, fibromyalgia. Pregnancy, there is an increased risk of musculoskeletal and neuropathic pain condition. Attitudes and beliefs about pain. People who have an active strategy to cope with pain, for example, exercise, do better than those with a passive approach, resting and taking medication. Complications of chronic pain include disability. If poorly controlled, chronic pain can lead to significant disability. Psychological distress, for example, depression and anxiety. Referral to occupational therapy and psychology may be required. It is estimated that around 48% of people with chronic pain also suffer from depression. Medicine misuse. This occurs in 25-30% of people with chronic pain taking opioids. Sleep impairment, negative effects on work, and loss of employment. Adverse effects from medication, for example, nonsteroidal anti-inflammatory drugs, NSAIDs, and opioids. The risk of harm from opioids increases substantially at doses above an oral morphine equivalent of 120 milligrams a day, but there is no increased benefit. Reduced quality of life, daily living, family and social relationships, and employment can be negatively affected by chronic pain. Prognosis. People with chronic pain usually experience symptoms lasting several months to years. Back pain that persists beyond the acute period often persists long-term. Myofascial pain symptoms normally persist long-term with fluctuating severity. Fibromyalgia. Complete remission rarely occurs, although most people experience substantial symptomatic improvement and reduced reliance on medicines when followed over 3 years. Analgesics can sometimes work effectively to relieve chronic pain. However, this is only achieved in a small percentage of people. It is unusual for any analgesic, including strong analgesics like opioids, to completely eliminate chronic pain. Non-pharmacological treatment may be effective in reducing symptoms and disability in some people with chronic pain and can also augment and complement analgesic use. Factors associated with a poorer prognosis include higher levels of pain severity and disability, longer duration of pain, multiple pain sites, history of anxiety and depression, maladaptive coping strategy, for example, worry, avoidance, low social support at the time of diagnosis. Diagnosis. Identify any red flag clinical signs and symptoms of serious underlying conditions that require urgent referral. Offer a person-centered assessment to people presenting with chronic pain, chronic primary pain, chronic secondary pain, or both, to identify factors contributing to the pain and how the pain affects the person's life. Take a medical history and carry out a biopsychosocial assessment. Ask the person about the location, the intensity, and the type of pain. Ask the person to point to the pain on themselves and use pain maps to define the location and extent of pain. Ask about the intensity of pain, and if this has changed over time, consider using a standardized intensity rating scale, such as a verbal rating scale, a visual analog scale, or a numerical rating scale. For example, the British Pain Society Numerical Pain Rating Scale. Ask about the characteristics of pain, for example, aching or stabbing, and any other accompanying symptoms, for example, numbness, weakness, to help identify the type of pain, for example, neuropathic, nociceptive, or mixed. About factors that help alleviate pain, or which exacerbate it, for example, rest or movement. About comorbidities and use of prescribed or over-the-counter medication. To describe how chronic pain affects their life, and that of their family, carers, and significant others, and how aspects of their life may affect their chronic pain. This might include effects on lifestyle and day-to-day activities, including work and sleep disturbance, physical and psychological well-being. A chronic physical health problem, such as pain, can both cause and exacerbate depression. Stressful life events, including previous or current physical or emotional trauma, current or past history of substance misuse, social interaction and relationships, difficulties with employment, housing, income, and other social concern. About their understanding of their condition and that of their family, carers, and significant others. This might include their understanding of what causes the pain, their expectations of what might happen in the future in relation to their pain, their understanding of the outcome of possible treatments. Assess the person's health-related quality of life, for example, using the Eurocall D-EQDL descriptive system. Explore the person's strengths as well as the impact of pain on their life. This might include talking about their views on living well, the skills they have for managing their pain, what helps when their pain is difficult to control. When assessing chronic pain in people aged 16 to 25 years, take into account any age-related differences in presentation of symptoms, the impact of the pain on family interactions and dynamics, the impact of the pain on education and social and emotional development. Conduct a physical examination to identify any treatable causes, for example, a musculoskeletal examination if there is evidence of inflammation, or a neurological examination if there is evidence of weakness or neuropathy. Think about a diagnosis of chronic primary pain if there's no clear underlying secondary cause, or the pain or its impact is out of proportion to any observable injury or disease, particularly when the pain is causing significant distress and disability. Make decisions about the search for any injury or disease that may be causing the pain, and about whether the pain or its impact are out of proportion to any identified injury or disease using clinical judgment in discussion with the person with chronic pain. Be sensitive to the person's socioeconomic, cultural, and ethnic background and faith group, and think about how these might influence their symptoms, understanding, and choice of management. Recognize that living with pain can be distressing, and acknowledge this with a person with chronic pain. An initial diagnosis of chronic primary pain may change with time. Reevaluate the diagnosis if the presentation changes. Chronic primary pain can coexist with chronic secondary pain. Be aware of signs and symptoms of serious underlying disease in people with chronic pain, such as cauda equina syndrome, back pain low without radiculopathy, sciatica, lumbar radiculopathy, giant cell arteritis, lung carcinoma. This may present as severe shoulder pain accompanied by Horner syndrome, multiple myeloma, subarachnoid hemorrhage, bone and soft tissue sarcoma, hematological cancers, gastrointestinal tract cancers, neck pain, trigeminal neuralgia, knee pain, shoulder pain, migraine, temporomandibular disorders. Other red flag features to be aware of in people with chronic pain include older age and new onset symptoms, people who are immunosuppressed, History of cancer, especially in people with back pain, abdominal pain accompanied by persistent vomiting in women of childbearing age, or people who have recently attended the accident and emergency department. Neurological features, fever, sweats, chills, unexplained weight loss, persistent, non-mechanical bone pain, pain that worsens at night or when supine. Investigations. Investigations for people with chronic pain will be determined by history and examination findings, but may include cancer screening tests, erythrocyte sedimentation rate, ESR or C-reactive protein, full blood count, thyroid function test, ultrasound or magnetic resonance imaging, MRI, scan. Management. The optimum approach is likely to involve other members of the multidisciplinary team, including nurses, pharmacists, physiotherapists, psychological therapists, counselors, and occupational therapists. It may also include liaison with social services, employers, and benefits agencies. Encouraging the patient to have an attitude of positive coping is beneficial. A compassionate, patient-centered approach to assessment and management of chronic pain is likely to improve the chances of successful outcome. Self-management should be encouraged from the early stage of a pain condition and as part of a long-term management strategy. There are no proven, comprehensive treatments in primary care for patients with medically unexplained symptoms. Management must be tailored for each individual patient. The treatment should not just be aimed at pain relief, but also at changing pain behavior and improving function. The goals of treatment must be realistic and should be focused on restoration of normal function, minimal disability, better quality of life, reduction of use of medication, and prevention of relapse of chronic symptoms. Referral to a specialist pain management service should be considered when non-specialist management is failing, chronic pain is poorly controlled, there is significant distress, and/or where specific specialized intervention or assessment is considered. Non-pharmacological chronic pain management. If any red flags are present, suggesting a serious underlying pathology, refer urgently or arrange immediate assessment, depending on clinical judgment. For all other people with chronic pain, discuss a care and support plan with the person and explore. Explain the evidence for possible benefits, risks, and uncertainties of all management options when first developing the care and support plan and at all stages of care. Use these discussions to inform and agree the care and support plan with the person with chronic pain and their family or carers as appropriate. Provide advice and information relevant to the person's individual preferences at all stages of care to help them make decisions about managing their condition, including self-management. Discuss with the person and their family or carers as appropriate the likelihood that symptoms will fluctuate over time and that they may have flare-ups. The possibility that a reason for the pain or flare-up may not be identified. The possibility that the pain may not improve or may get worse and may need ongoing management. There can be improvements in quality of life even if the pain remains unchanged. When communicating normal or negative test results, be sensitive to the risk of invalidating the person's experience of chronic pain. For people with underlying conditions that cause chronic pain, treat the underlying cause where possible. For all people with chronic primary pain, offer a supervised group exercise program. Encourage people to remain physically active for longer-term general health benefits. Exercise and physical therapy evidence in 23 studies showed that exercise reduced pain and improved quality of life in 22 studies, compared with usual care in people with chronic primary pain. Benefit was seen for both short and long-term follow-up and was consistent across different types of exercise. Most of the evidence was for professionally led supervised group exercise and for women with fibromyalgia or people with chronic neck pain. There is limited evidence comparing different types of exercise with each other. Consider acceptance and commitment therapy, ACT, or cognitive behavioral therapy, CBT, delivered by healthcare professionals with appropriate training. Acceptance and commitment therapy evidence shows that ACT improves quality of life and sleep and reduces pain and psychological distress. Although clinical evidence was from a fairly small number of studies, NICE agreed that a CT was likely to offer a good balance of benefits and costs and so recommended that it should be considered as a psychological therapy for chronic primary pain. Cognitive behavioral therapy evidence shows that CBT for pain improves quality of life for people with chronic primary pain. A consistent benefit was not demonstrated in other outcomes, but there was no strong evidence of harm. Economic evaluations show CBT to be cost-effective. There was not enough evidence to support a preference for a CT over CBT or CBT over a CT. Consider a course of acupuncture or dry needling within a traditional Chinese or Western acupuncture system, but only if the course is delivered in a community setting and delivered by a Band 7 equivalent or lower healthcare professional with appropriate training, and is made up of no more than 5 hours of healthcare professional time. The number and length of sessions can be adapted within these boundaries, or is delivered by another healthcare professional and/or in another setting for equivalent or lower cost. Self-management advice. Self-management can be used from the early stages of management through to long-term management and can complement other therapies. Encourage people to participate in structured programs that aim to allow them to take an active part in management of their condition. Signpost people to self-help resources identified and recommended by the local pain services. Internet-based self-help materials can also be a beneficial adjunct to clinical care for short-term pain relief, reduction in perceived disability, and improvement in stress, coping, and social support. For example, the British Pain Society, BP, leaflet Understanding and Managing Long-Term Pain, the website's pain toolkit, and arthritis care. Provide advice information about diet, weight, alcohol use, smoking, and exercise for improving or maintaining health. People with chronic pain require advice and specific instructions on appropriate exercise and/or restoration of functional activities to promote active self-management. Manage flare-ups and setbacks. Keeping a pain diary to monitor pain intensity. Electronic diaries may be better than a paper diary for keeping an accurate contemporaneous account. Follow-up people with chronic pain or taking analgesics at least annually, and more frequently if medication is changed or the pain syndrome and/or underlying comorbidities alter. Confirm the ongoing need for and effectiveness of the medication. Screen for adverse effects and adjust the dose or discontinue as appropriate using a holistic polypharmacy approach. People with chronic pain using antidepressants should be reviewed regularly and assessed for ongoing need to ensure that the benefits outweigh the risks. Offer a reassessment if a person presents with a change in symptoms such as a flare-up of chronic pain. Be aware that a cause for the flare-up may not be identified. If a person has a flare-up of chronic pain, review the care and support plan. Consider investigating and managing any new symptoms. Discuss what might have contributed to the flare-up. Reevaluate pain using the scale used at initial assessment to evaluate the effects of treatment. Refer people to a pain specialist when appropriate. Referral arrange specialist referral for people with chronic pain. The urgency depending on clinical judgment if there are red flag signs and symptoms that may indicate serious underlying pathology. Non-specialist management is failing. Chronic pain is poorly controlled. There is significant distress, where specific specialist intervention or assessment is required. Chronic regional pain syndrome is suspected. Pharmacological chronic pain management. Consider an antidepressant, either amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, or sertraline for people aged 18 years and over after a full discussion of the benefits and risks. If an antidepressant is offered to manage chronic primary pain, explain that this is because these medicines may help with quality of life, pain, sleep, and psychological distress, even in the absence of a diagnosis of depression. Note that this is an off-label use of these antidepressants. Seek specialist advice if pharmacological management with antidepressants is being considered for young people aged 16, 17 years. Non-opioid analgesics, non-steroidal anti-inflammatory drugs, NSAIDs, should be considered in the treatment of patients with chronic non-specific low back pain. When prescribing NSAIDs, consider potential gastroenterological and cardiological adverse effects and assess the individual's risk. Paracetamol should be considered alone or in combination with NSAIDs in the management of pain in patients with hip or knee osteoarthritis, in addition to non-pharmacological treatments. Topical NSAIDs should be considered in the treatment of patients with chronic pain from musculoskeletal conditions, particularly for patients who cannot tolerate oral NSAIDs. Topical capsaicin patches should be considered in the treatment of patients with peripheral neuropathic pain when first-line pharmacological therapies have been ineffective or not tolerated. This is from SIGN guidance for chronic pain. NICE guideline on neuropathic pain advises this is only used under specialist advice, although it gives capsaicin cream as an option. Topical lidocaine should be considered for the treatment of patients with postherpetic neuralgia if first-line pharmacological therapies have been ineffective. Topical rubefacin should be considered for the treatment of pain in patients with musculoskeletal conditions if other pharmacological therapies have been ineffective. Opioids. Over recent years, there has been a significant increase in prescribing of opioids in the UK for chronic, non-cancer pain. There is no good quality evidence to support the use of opioids in this situation. Strong opioids should not be offered to treat chronic low back pain. Strong opioids may be considered as an option for pain relief for patients with osteoarthritis if alternative analgesia has not been tolerated or effective, but only continued if there is ongoing pain relief. Tramadol, oxycodone, and morphine are not recommended for chronic neuropathic pain unless under advice from a specialist. The minimal effective dose should be used. All patients on strong opioids should be assessed regularly for changes in pain relief, side effects, and quality of life, with consideration given to a gradual reduction to the lowest effective dose. It may be necessary to trial more than one opioid sequentially, as both effectiveness and side effects vary between opioids. Signs of abuse and addiction should be sought at reassessment of patients using strong opioids. Specialized referral or advice should be considered if there are concerns about rapid dose escalation with continued unacceptable pain rel, or if more than 180 milligrams day morphine equivalent dose is required. Anti-epilepsy drugs. Pregabalin and gabapentin can lead to dependence and should be prescribed appropriately to reduce the risks of misuse or depend. Gabapentin should be considered for the treatment of patients with neuropathic pain. Pregabalin is recommended for the treatment of patients with neuropathic pain if other first and second-line pharmacological treatments have failed. Pregabalin is recommended for the treatment of patients with fibromyalgia. A 2017 Cochrane review concluded that high doses of gabapentin can give good levels of pain relief to some people with postherpetic neuralgia and peripheral diabetic neuropathy, but there is limited evidence of benefit for other conditions. Over half will not have worthwhile pain relief and may have adverse effects. A Cochrane review of pregabalin had similar findings. Failure to respond after an appropriate dose for a test period should result in stopping pregabalin or gabapentin and a trial of a different medication. IGN recommends that carbamazepine should be considered for the treatment of patients with neuropathic pain. A Cochrane review assessed it as being probably effective in some, but further studies are needed as evidence is limited. NICE recommends carbamazepine as first-line treatment for trigeminal neuralgia. Antidepressants. Patients with chronic pain conditions who are using antidepressants should be reviewed regularly. Tricyclic antidepressants should not be used for the management of pain in patients with chronic low back pain, although they may be considered for sciatica. Amitriptyline, 25 to 125 milligrams per day, should be considered for the treatment of patients with fibromyalgia and neuropathic pain, excluding HIV-related neuropathic pain. Although a recent Cochrane review found little convincing evidence of its benefit for neuropathic pain. Serotonin noradrenaline reuptake inhibitors, SNRIs, may be superior in efficacy and with regard to adverse effects. Duloxetine should be considered for the treatment of patients with diabetic neuropathic pain if other first or second-line pharmacological therapies have failed. Duloxetine should be considered for the treatment of patients with fibromyalgia or osteoarthritis. Fluoxetine should be considered for the treatment of patients with fibromyalgia. Depression is a common comorbidity with chronic pain. Patients should be monitored and treated for depression when necessary. Amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, or sertraline can be used for people aged 18 years and over to manage chronic primary pain after a full discussion of the benefits and harms. In April 2021, This was an off-label use of these antidepressants.